Since we are here for the World Sight Day, it is about reminding you to love your eyes. We are calling all stakeholders to help people prioritize their own eye health and leaders to ensure eye care is accessible, inclusive, and affordable to everyone and everywhere. Nearly everyone on the planet will experience an eye health issue in their lifetime. However, more than 1 billion people worldwide do not have access to the services they need to see clearly. The World Sight Day 2023 campaign encourages individuals to prioritize their own eye health while advocating for accessible, affordable, and available eye care the world over. Working together, we are hoping to have 5 million sight test pledged post screenings and show the world how to love your eyes with our fun and engaging social assets. I'm your host, Dr. Rakesh Gupta, President Sipher and former Director of Health Services, Punjab. I welcome you all for this special presentation on dry eye syndrome, causes, symptoms, and management. It is specially recorded for Docplexus and Sipher Health News channel, coinciding with the World Sight Day 2023 celebrations. We feel honored to have with us an eminent ophthalmologist and corneal surgeon, Dr. Ashok Sharma, with us. Dr. Ashok Sharma is Director, Cornea Center, and he is ex-president, Chandigarh Ophthalmological Society, founder, Honorary Secretary, Eye Bank Association of Chandigarh, and is ex-member, Executive Committee, Eye Bank Association of India. He is a former Associate Professor of PGIMER Chandigarh. He is a Cornea Fellow of L.V. Prasad Eye Institute, Hyderabad. He was an eye consultant in Maryland, USA, has published more than 100 research papers in the peer-reviewed national and international journals. He has been awarded by American Academy of Ophthalmology, AO Achievement Award, AO International Scholars Award, and AAO Best Poster Pediatric Corneal Transplants. So Best Paper Award, SSI Conference for Fibrin Glue, that was in 1998, and Best Paper for Dry Eye in JRA at National Conference 2000. And he became our Cornea Hero Award for Sipher Chandigarh in 2020. So over to Dr. Ashok Sharma. So you are welcome.
Thank you, Dr. Rakesh Gupta, for nice words. I shall be speaking on dry eye syndrome, causes, symptoms, and management. Dry eye, as we know, is a very common problem, and in general population the prevalence has been estimated to be around 30 to 40%. Now if we look at the prevalence in cornea clinics, the incidence or the prevalence is more than 50%. The prevalence of dry eye also increases with the age. And therefore, if we take the population who undergoes cataract surgery, the prevalence still goes higher. So we can see that the dry eye problem is common problem and is affecting most of us. Before we go on to the proper topic of dry eye, we need to look at the tear film which is present on the cornea, and the outermost layer is basically lipid layer, which has two components, non-polar and polar lipid layer. Interestingly, this layer is being secreted by the meibomian glands present in the eyelids, and most of the times we are not talking about it, but this is very important to prevent the evaporation of the tears. Beneath this is basically aqueous layer, which consists of salts, proteins, gel-forming mucins, etc. And this aqueous layer is supported by protein layer, which is on the corneal epithelium. So, to have the stable tear film, we need to have all the components in proper proportion. So the tear film has a hydrating effect on the corneal surface, and it also nourishes the corneal epithelium. Aqueous layer is secreted by the lacrimal gland, and lipid layer, as we discussed, it acts as a layer to decrease the evaporation of the aqueous layer. So this balance of the tear film is very important to have the normal ocular surface and normal functioning of the cornea, because cornea is the window of the eye. It not only transmits the light but also focuses the light onto the retina. So any disturbance in the dynamics of the tear film will cause dry eye. Now there are several definitions which have been given for dry eye, but the most common definition is that dry eye is a multifactorial disease of tear and ocular surface that results the symptoms of discomfort, visual disturbance, tear instability with potential damage to ocular surface. And this is accompanied by increased osmolarity of the tear film and also causes inflammation of the ocular surface. At the same time, equally important is the function of the meibomian gland. And once the meibomian gland dysfunction occurs, we call it in short MGD. This again is a chronic diffuse abnormality of the meibomian glands, commonly characterized by the terminal duct obstruction, causing qualitative and quantitative changes in the glandular secretions. This may result in the alteration in the tear film, symptoms of irritation, and clinically apparent inflammation and ocular surface disease. So the two problems combined, they cause dry eye. This is just to show that the normal ocular surface needs normal tear film, and in addition to that, it also needs another component, that is the normal corneal innervation, corneal nerves. So in case there is the disruption of the nerve or the neural arc, then the impulses which go to the lacrimal gland are disrupted, and we do not get the normal tears. Because of the disruption, we get inflammation in the ocular surface, which is indicated by chronic irritation, T cell activation, and cytokine secretion into the tears. We also call it toxic tears. And this is just to show that dry eye is a multifactorial disease, as we discussed, and of four important pathogenetic mechanisms like tear film instability, hyperosmolarity, apoptosis, and inflammation. It is the inflammation which is the most important, and inflammation of the ocular surface occurs in all kinds of dry eye, whatever may be the cause. Now this shows basically the presence of the normal tear constituents in healthy eye, whereas in case dry eye develops, that person's tears will contain lot of cytokines and other mediators of inflammation comparison to the normal and healthy eye. So in chronic dry eye, the tear constituents are changed, and they are having lot of inflammatory components which affects the ocular surface and causes the inflammation of the ocular surface. Till now we have discussed two aspects. One is basically the aqueous secretion which comes from the lacrimal gland, and the other one we discussed was the lipid secretion which comes from the meibomian gland. So there can be abnormality in one, there can be abnormality in the other, or there can be abnormality in both the lacrimal gland as well as meibomian glands. So the aqueous deficiency dry eye is the dry eye which is caused by the impaired lacrimal function. Evaporative type of dry eye is the dry eye caused by the meibomian gland functions. In majority of the cases these days, especially post-COVID-19 era, we are getting the meibomian gland dysfunction or evaporative dry eye much more common than the aqueous deficient dry eye, which we used to get more frequently previously. So nowadays, whenever we are getting a dry eye patients, most of the times either it is evaporative type or it is having both the components, aqueous deficiency as well as evaporative dry eye component. Now, these are some of the causes of aqueous deficiency or aqueous deficient dry eye. These are mainly basically a group which is grouped into basically immune-mediated lacrimal gland inflammation, and this occurs in a very important disease known as Sjogren syndrome. And this also occurs in autoimmune disorders like rheumatoid arthritis. Another group is very important, but will not go into the details of this group. This is basically a group where the cicatrization of the conjunctiva occurs. And this can be progressive. And in progressive group, we have mucous membrane pemphigoid or drug-induced cicatrization conjunctivitis. Then there can be non-progressive Stevens-Johnson syndrome. Non-progressive does not mean that the dry eye will not progress or the ocular surface will not deteriorate. It deteriorates, but the insult is only once because of the drug reaction. Stevens-Johnson syndrome occurs, and insult is occurring only at one time. But the disease will be of progressive nature. Again, diabetes, iatrogenic causes, they are important. And then certain causes which affects the lacrimal gland function. Two another important causes are, one is systemic medication. There are a number of medications which causes dry eye, especially antidepressants or antipsychotic medications, antidepressant medications. And another group of patients is those who are at the menopause age, because menopause again causes the hormonal changes which leads to the dry eye. Now, if we look at the causes of the evaporative dry eye, we have causes which cause the meibomian gland dysfunction. I will not go into those details, but then we have another group of disorders where the ocular surface is damaged, especially vitamin A deficiency or chronic allergies. Then systemic diseases, like most of these are dermatology problems, psoriasis, ectasis, atopic dermatitis, seborrheic dermatitis, rosacea. And then other causes which can be like lid disorders, blink-related, Parkinsonism disease, or contact lens wear. So all these diseases can cause meibomian gland dysfunction. Now, coming to the symptoms, we have so many symptoms of dry eye, and they are debilitating symptoms. You cannot basically read a book, you cannot drive, you cannot tolerate sunlight, you will have intolerance to light. So many issues will be there. Your normal daily routine life will be affected, and these are various symptoms in which the patient approaches us. Most of the times the patient have watering. Once the patient with watering comes to us, he will always say that, "Doctor, you are telling that I am having dry eye, but I am having so much of watering." So that is a basically paradoxical secretion, and we get because there is irritation and we get watering, reflex watering. That is not basically the true or the basic tears which the patient has. Now, if we come to the size, we have to look for the marginal tear strip, and this height is less. Conjunctival congestion will be there. On the cornea, there may be punctate epithelial erosions, abrasions, filaments, as well as the mucus discharge. In addition to the dry eye, which we categorized into two, like aqueous deficient as well as the evaporative dry eye, we usually try to classify dry eye into another group like which we showed a few slides back, that it is just basically a dry eye, aqueous deficiency or evaporated, or we have underlying autoimmune disease. Because if we have underlying autoimmune disease, then we need to diagnose and treat this underlying autoimmune disorder. Because unless we treat this disorder, dry eye may not improve and the patient may suddenly get some serious problem like epithelial defect or corneal melt or corneal perforation, and the eye may be lost. So it's very important to diagnose the underlying autoimmune disorder or to rule out it. And if it is present, we need to treat it, and we usually take the help of rheumatologist. Now, another group which I told was Stevens-Johnson syndrome and ocular pemphigoid. For these group of disorders, again, we need special treatment, and we will not go into the details about these problems. Coming to dry eye evaluation and treatment, there are large number of tests which can be done to diagnose dry eye. And these are some of them, like tear film breakup time, Sharma test, ocular surface fluorescein filters, and stains like glycine green. All these tests they can be done to demonstrate dry eye and to demonstrate the ocular surface damage. But this test is very important, which is non-invasive tear film breakup time. Now, for this tear, we just put very small amount of fluorescein stain, and we ask the patient to look straight on cobalt blue filter. We get this green fluorescence, and if we don't ask the patient to blink, and then we count the seconds. So you can see these dark areas appearing. The moment these dark areas appear, this means that the tear film has broken up, and the duration after which it has broken up is basically tear film breakup time. In normal eyes or with the normal tear film, it's more than 10 seconds. So this is very important test. There are some other tests like on CILTEM, we can examine the tear film height, tear film debris, mucostrands. All these are indicative of presence of dry eye. These are the stains which can be used to demonstrate the ocular surface damage. Of these, fluorescein and glycine green we use frequently. Rose Bengal we don't use unless we are doing some research work, because this is very irritating to the ocular surface. In addition to this, basically, we also have like some of the questionnaires with which we can diagnose the dry eye, and we have tests like mammography. Now, in this you can see the eyelids, and in the eyelids, if you see, we are seeing those meibomian glands, and there are areas where there are no meibomian glands seen. So we call it the dropout of meibomian glands. So this is important test with which we can know the how much meibomian glands are there, and if there is a lot of dropout of meibomian gland, that means the meibomian gland atrophy is there. This is another clinical examination of the meibomian glands. You can see the opening of the glands, and then these glands, they are blocked because of the squamous metaplasia. And on the lid margin, neovascularization again is indicative of meibomian gland dysfunction. We were talking of cicatricial disease like OCP. We can see the inferior part of the conjunctiva. We have fibrosis of conjunctival fibrosis, which is indicative of conjunctival scarring. And if this occurs, this shows that the patient has a serious disease of ocular cicatricial pemphigoid. We can go for the biopsy, and we need special treatment for these patients. All said and done, the treatment of dry eye needs artificial tear drops. And we have several categories of artificial tear drops, like cellulose derivative products, oil-based emulsion products, glycerin-containing products, sodium hyalurate products, and polyethylene glycol propylene glycol products. So of various products, we can choose the various artificial tears, and we can treat our patients. But the basic principle remains that if we need to treat moderate or severe dry eye, then we need preservative-free artificial tear drops. And if we are using gels or carbomeres or ointments, We use these for severe disease because they have higher viscosity. Artificial teardrops with HP guar, they are especially useful in evaporative disease. And artificial tears containing lipid triglycerides, again, they are used for evaporative type of disease. Hyaluronic acid and HP guar, they provide greater hydration and epithelial barrier protection. So we can this reduce the epithelial friction. Osmoprotectants, L-carnitine, erythritol, betaine, they protect the ocular surface epithelial cells. Ribapamide was introduced with the objective to improve the mucin secretion, but this is no longer used these days. In addition to artificial teardrops, we have several other modalities of treatments which are needed, like omega-3 fatty acids, punctal plugs to prevent the drainage of the tears, or the artificial teardrops into the nasal cavity. Then we can also use drugs like pilocarpine, which increase the secretion of tears. Autologous serum is very useful if patient has epithelial defect which is not responding to conventional treatment. Then like bandage contact lenses or scleral contact lenses are also very useful. Systemic immunosuppressive treatments, I told you, for those patients who have underlying autoimmune diseases. Sometimes when the patient has severe ocular damage in the form of non-aging epithelial defect, or they have got lid margin keratinization, then they need special treatment in the form of amniotic membrane transplants or mucous membrane grafting of the lid margins. The special patients may be benefited by moist chamber spectacles, but they are not commonly used these days, but they are available. So these are some of the modalities which I just mentioned, and tarsography sometimes is needed because this will decrease the area and it will improve the ocular surface. Punctal occlusion is important, and we can occlude where we have two puncta on either side, and upper and lower. It's a lower puncta which drains 80% of the tears, so we can occlude this punctum by putting the punctal plugs. I usually prefer permanent punctal plugs. Temporary plugs, they get absorbed and they are not very useful. Now coming to some of other treatment options like topical cyclosporine. This is very useful, and this basically controls the ocular surface inflammation and prevents the deterioration of the ocular surface. Only thing is that when we instill the drop of cyclosporine, there may be a little bit of irritation. So we usually prescribe patients some drops of steroids for a few days so that the patient can tolerate it. And also it takes time to get the effect of topical cyclosporine. It takes almost 3 months to get the effect of this medicine. And if we use this medicine for a longer period, we don't have any systemic side effects. MGD we discussed, and it needs to be treated very seriously. And the best treatment is that you need to give warm compresses to the lids so that the temperature of the glands that is raised, and this will help in liquefying the secretions of these glands. You can see that the secretions coming out of these glands with MGD are very thick, and it's very difficult to bring these secretions out. So once we do the warm compresses, then we do compression of the lids or digital massage of the lids so that we can express these secretions out. Improved eyelid hygiene is necessary. We have these days many lid wipes available, medicated lid wipes, and they will be very helpful. We usually give doxycycline for 3 weeks, or we can use azithromycin for a short period of 3 days. Topical cyclosporine again is useful for mammalian gland disease. Same is the true for omega-3 fatty acids. So this MGD needs to be treated properly. Before we move further, it will be very important to discuss about computer vision syndrome. No discussion on dry eye will be complete without mentioning this problem, because in post-COVID era, the screen time has significantly increased, and most of the times, even the children who are going to school, they get homework through the mobiles, and they need to look at that, and then also for their recreational activities, they look at the video games or TV programs. So screen time has significantly increased. What happens when we look at the screen, or we drive, or we concentrate, that our blink rate goes down. Normally, eye blink rate is 16 times per minute, but it significantly drops down when we look at the screen or we drive. So because of that, the relative dryness is produced. And those patients who have already dry eye, they become very much uncomfortable, and they will not be able to use computer, or they will not be able to drive unless they put eye drops. So there are so many symptoms for that, and we need to take care of this problem by taking one is by sitting at a proper posture, so that you don't get into other problems. You have to have a proper distance from the your laptop or your mobile, and your back should be straight, so that you don't develop another problem of neck stiffness or back pain or other problems. As far as eye is regarded, we need to blink frequently when we are not looking at the screen, and we can increase the text size. We need to use artificial teardrops. If we are not getting the relief, then we need to get our eyes checked, because we may be having some refractive error which needs correction. In addition to that, one has to take healthy food, healthy distance we have to maintain, exercise, body exercise, then proper light. Because if you have you are working in a brighter light, then you have to decrease your brightness of your screen. If you are working in a dim light, then you have to increase the brightness of your screen, so that the brightness of your screen is optimal. At the same time, you have to use blue light filters. They are especially useful in decreasing the eye strain because of the computer vision syndrome. Another area is those patients who undergo refractive surgery, especially LASIK. If these patients, they have dry eye, they need to be treated properly before undertaking the procedure, because a significant number of the patients, they are unsatisfied after LASIK surgery, and that is because of the dry eye. So we have to take care of this problem beforehand. And in one of the studies or the FDA clinical trials, it has been found that 21% of the patients, they were bothered by the dry eye. So we need to treat these patients after LASIK. Even if the patient is not having dry eye, following LASIK, the patient may develop dry eye, because we are cutting almost all the nerves, and there is a state of denervation of the cornea. And because of the denervation of the cornea, the tear secretion is affected. And we need to use artificial teardrops for about 4 to 6 months after surgery in these patients who have symptomatic dry eye. If the patient doesn't have symptomatic dry eye, then we use only for the 3 months or so. Then another area is for those patients who undergo cataract surgery. We have already discussed that the incidence of the dry eye is very high in those patients who have to undergo cataract surgery. And you will be surprised to know that 87% of the cataract surgery patients with dry eye, they become symptomatic after cataract surgery, even if they are not having symptoms before cataract surgery. 50% of the cataract surgery patients with dry eye, they have evidence of ocular surface damage on cornea staining. 35% of the patients, they are dissatisfied, and that is not because of the cataract surgery procedure, but because they have dry eye and the cataract surgery has been done excellently, but they are unhappy because of the dry eye. And we published one report long time back for patients who we did cataract surgery, and they were having severe dry eye. And it was seen that the number of complications were much higher in those patients who had dry eye, and especially those patients who have a dry eye with underlying autoimmune disorders. These patients, they had something serious complications like infective keratitis, endophthalmitis, filamentary keratitis. So it's very important that a dry eye should be properly treated before we undertake cataract surgery in patients who have dry eye. Now, this slide shows that the patient below is on the left side has undergone cataract surgery without diagnosis of dry eye, and she developed infection and the eye was lost. And the other eye was treated for dry eye. Then we did cataract surgery and we could save this eye and eyesight. And the patient is doing a daily routine because of this eye only. Above is the patient who again was very influential person in Chandigarh, and he had very severe dry eye and SPK, lot of SPKs. And he will go to any doctor in the country and will ask, I want cataract surgery. Everybody will say, okay, we'll do tomorrow, without seeing at the severity of the dry eye, without seeing the SPKs. And if we have done cataract surgery in presence of SPKs, he would have got the same problem which this patient has got in the left eye below. So we treated this patient with topical cyclosporin, artificial tear drops, autologous serum drops, and we also occluded the punctum. We placed the punctal plug in this eye. So then we did cataract surgery, and now he's 92 years old and still enjoying good vision with this eye. So it's very important that you treat dry eye and then take these patients for cataract surgery. I've seen most of the patients being operated without treating dry eye, which will be detrimental. This is another patient who had very severe dry eye, and she had corneal ulcers in both eyes. 4 people brought her, and she had some problem in the lens also. She has to be lifted. Once we treated her for dry eye, we put amniotic membranes to treat her ocular surface, and we gave her systemic immune suppression. Then we did cataract surgery in both eyes. She is now mobile, she are able to see, and she is enjoying her life. So we need to take care of these things like dry eye and its complications, that then do the cataract surgery. Again, another patient having bilateral severe dry eye with corneal problem and operated after controlling the dry eye or treating the dry eye, enjoying good vision. So in short, I would like to say that severe dry eye is a big problem, and it's just like desert where nothing can grow. And if the patient is having very severe dry eye, you cannot do any surgery also. And if we do surgery in these patients, we get complications. It's just like desert. But the desert can be converted into the forest. These are the pictures from Israel, Jerusalem, where the desert has been converted into the forest. You can see the beautiful forest. So same way, we can get very good results in dry eye patients after surgery if we treat the dry eye first and make the ocular surface healthy and then operate these patients. Now, before I sum up, I would like to say that eyes are powerful, eyes are delicate, eyes are beautiful. Theodore Roosevelt once said, keep your eyes on the stars and keep your feet on the ground. So if you treat the dry eye, you can keep your eyes healthy and you can enjoy the life beautifully. In the end, I would like to say that we have few key messages in this presentation. One is that dry eye is an underdiagnosed condition. It is much more prevalent than the diagnosed in the clinics. And evaporative dry eye is on the rise, as we discussed. It's on the rise. The reasons we don't know. Maybe because of the post-COVID use of digital gadgets. There is ocular surface inflammation, and that is causing the blockage of the moving glands. But this is true that at least out of 4 or 5 patients, we have out of 5 patients, we have 4 patients who have evaporative dry eye, either alone or in combination with aqueous deficiency dry eye. In addition to that, we have to rule out systemic autoimmune disease, and in case we find one, we need to treat it properly and in addition to the dry eye treatment. Post-COVID era, we are getting much more incidence of computer vision syndrome, and we need to diagnose it, we need to prevent it and treat it with adequate measures. Again, the last but the most important message is that if we want to operate a patient who has dry eye, either we have to do LASIK surgery or cataract surgery. We need to treat the dry eye very efficiently, and we have to build up the ocular surface to the extent that even if the dry eye worsens after cataract surgery, the patient doesn't become symptomatic. Most of the patients who have dry eye and they are not symptomatic before cataract surgery or before LASIK, they will become symptomatic after the LASIK or the cataract surgery. We need to counsel our patients on this account. Thank you very much for patient hearing. Thank you so much. And I thank Dr. Rakesh Gupta for giving me opportunity. Thank you.
Well, thanks a lot, Dr. Ashok. I think all the general physicians as well as the general ophthalmologists will benefit a lot. You have summarized it very nicely. The picture of the Yatir forest, Jerusalem, I think people will know. So what wonders you can do by treating dry eyes. And the key messages were excellent. That it is a underdiagnosed condition and evaporative dry eye. It is on the rise because of the meibomian gland disease. Then rule out systemic autoimmune disease. I think that is very important. And post COVID-19, we have seen that people, they are using more computers now. Even the kids are using computers. So we need to be very informative about the dry eye conditions and treat dry eyes before LASIK or cataract surgery. I think that is very important. We should not be hurry with doing LASIK or cataract. We must always treat these conditions, the dry eyeness in these patients first for a wonderful experience. So thanks a lot. And I've shared my your mail and my mail for any queries by the viewers. So I think so if there's any query, they can put the queries and we'll like to answer those queries. So thanks a lot, Dr. Shah. Thank you.
Okay.